Okay, fantastic. So now I am delighted to introduce our speakers. Um, Dr. Sarah Chung is an assistant professor of psychiatry um, at the University of California, San Francisco. Her research focuses on improving the utilization, contextual relevance, and scalability of evidence-based interventions for attention and behavioral challenges in community settings. She serves as a co-investigator and lead trainer for school mental health clinicians and clinical psychology trainees in the Collaborative Life Skills Program, which is a three-component intervention delivered in public elementary schools. Dr. Chung is a licensed clinical psychologist and conducts individual, family, and group therapy in the UC San Francisco Hyperactivity Attention and Learning Problems Clinic. Uh, Alongside Dr. Chung is Dr. Yesenia Mejia, who is a bilingual licensed clinical psychologist and core faculty member at the AltaMed Family Medicine Residency Program. She supports faculty and residents through precepting and teaching about the psychological and social factors influencing health, while also advising residents on research projects. Dr. Mejia provides behavioral health therapy to patients, and her research, clinical, and advocacy work is dedicated to reducing inequities in mental health care access and engagement for underserved youth and families. She has expertise in culturally attuned mental health conceptualization, assessment, and treatment with a focus on increasing access to evidence-based service for Latina communities and youth with neurodevelopmental needs. So with that, I think we will turn it over to Dr. Chung and Dr. Mejia to hear about their exciting work through their InStep Pilot Award.
All right, thank you so much for that introduction. It's so great to be able to share our work. Let me just get my slideshow situated. All right, does that look okay?
Looks great.
Great.
Thanks, Sarah.
Great. And everyone feel free to jump in with any questions. We have a whole bunch of slides to run through with you all, but it's okay. We don't have to cover all of them. We're just curious to hear some thoughts because both of us are quite new to some of this work as well.
All right, well, I will go ahead and start us off. I'm really excited to be here and excited to see some familiar names here as well. And so today we're going to be presenting some very exploratory and preliminary findings from our project focused on exploring psychological safety in diverse school mental health teams. And so before we dive in, we first want to say a big thank you to the InStep Children's Mental Health Research Center that funded our project. We also want to say a huge thank you to the R01 Enhancing Team Effectiveness for a collaborative school-based intervention for ADHD. We are so fortunate to be able to explore our project aims through using data and expanding on this larger project. So we're grateful for that. And then of course, our study participants. We also want to thank our data collection team as well at SDSU and UCSF. And so just to give a brief overview of what we'll be reviewing today, we'll review a little bit of background for our project aims, and we'll spend most of the time discussing the preliminary findings and with reviewing our next steps for the project. And so our project and collaboration really stemmed from Sarah and I's shared interest in disparities in mental health care for diverse families in community settings. And so there is ample literature that highlights how Asian American and Latina communities face persistent disparities in mental health care. And specifically, we see this for ADHD. And there's also a lot of research that shows that mental health teams are key avenues for engaging families and improving disparities in services. And unfortunately, there are many barriers to utilizing and engaging in mental health services for families. And specifically for Asian American and Latina families, we see that these experiences or these barriers include experiences of racism, discrimination, a lack of trust, stigma, and cultural values and attitudes related to open expression and or related to their how they view the family role and the school role. And we really believe that these experiences play into how comfortable or how psychologically safe they perceive these team environments to be. And so, what is psychological safety? It's the perception that it's safe to take interpersonal risks and share new ideas with the team. And we believe that this may be especially relevant for Asian and Latina caregivers engagement in their child's school mental health treatments and in their overall outcomes. So far, at least to our knowledge, no studies have examined psychological safety in school mental health team settings and or with caregivers included as team members. We also know that there is very little known about how teams with diverse cultural backgrounds experience psychological safety. And there's only one observational measurement of psychological safety currently, and we need more observational measurements of psychological safety so that we can begin to, or we need to hone them to begin to identify culturally relevant targets of intervention that can help us achieve more equitable service use and more equitable outcomes across the board.
We're trying to cover a lot of ground.
School mental health team. So sorry about that. Thank you for that question in the chat. So that brings us to our aims. And so our project consists of 3 aims. We, with our first aim, we wanted to examine quantitative and qualitative data on team members' perceptions of psychological safety and use that to identify the cultural relevance of the psychological safety observational measure items in the school mental health teams. Just wanted to highlight that as part of our aim 1, we were hoping to complete a semi-structured qualitative interview that unfortunately we were not able to complete. And Sarah will talk a little bit more about the workaround that we did to instead. Another sort of shift that we had to do was we dropped in a acculturation measure that we had. And this was really due to, we had a really low response rate, and we believe it had something to do with our current socio-political climate. And so we decided to drop that measure. For our second aim, we wanted to measure observed team psychological safety in school mental health teams that included Asian and Latina caregiving team members, and assess correlations between the team level psychological safety and some caregiver reported implementation outcomes. And then for our third aim, we really wanted to examine the convergent and predictive validity of the psychological safety observational measure. That's what the PSOM is. In these diverse teams implementing an EBT for an evidence-based treatment for ADHD. And I just wanted to quickly present our conceptual model for this project. And so here we have our clinical service or evidence-based treatment is the collaborative life skills intervention, which Sarah will describe in a bit. Our team inputs were member characteristics, in our case, race, ethnicity of the caregivers. For our implementation strategies, we had the CLS as standard, and then the team enhanced CLS, which again, Sarah will explain in just a bit. Our team mechanism was psychological safety. And so we were looking at observer rating of team level psychological safety, and then also a team psychological safety scale. And then our outcomes were the implementation outcomes, parent ratings of appropriateness, acceptability, and feasibility of the CLS intervention, and then caregiver reported engagement.
And for the purposes of our talk today, we'll explain this in the next steps as well, but we'll focus mainly on aims 1 and aim 2, the measurement of psych safety. All right, so just a really brief overview of CLS. Nicole gave a quick snapshot of that. Thank you at the beginning. But for those of you unfamiliar, CLS is an evidence-based school home collaborative intervention for kids with attention and behavior challenges. It was developed by Dr. Linda Pfeifner, who's on this call. Hi, Linda, at UCSF, and it provides around-the-clock support at school and at home via 3 components. And so there's a weekly parent skills group. It spans across 8 weeks. Parents come to the group either through online, Zoom, or in person, and they learn 1 to 2 new skills every week. There's also a weekly student skills group that runs parallel, and so that's also 8 weeks. They learn 1 to 2 new child skills every single week. And then there's a classroom support plan that's implemented by the teachers on a daily basis. And that is basically a daily report card where they create goals with a student, track their progress, and everyone comes together to discuss the progress at home and at school. And CLS has been implemented in now, I think, over 60 schools, if not more, in California and Mexico. And so the team enhanced version then is CLS standard with the implementation of 3 team effectiveness strategies, which are focused on enhancing communication and collaboration among these team members. But for the purpose of our talk today, we won't focus on the different components and the different versions of the implementation. We're looking at everyone all together and the psychological safety within the teams.
And then in terms of demographics, we currently only have the caregiver demographics available to present. The rest of the demographics are coming. But just to kind of highlight a couple of things here, we have the caregivers from the San Diego schools on the left-hand side and the San Francisco schools on the right-hand side. And so as you can see, in terms of the caregiver age, the San Diego caregivers are slightly younger. In terms of the caregiver race ethnicity, we see that the distributions are much higher in San Francisco for the non-Hispanic white families or population, and then a higher or a huge proportion of the Latina population is coming from the San Diego schools. In terms of caregiver education and family annual income, we also see that the San Francisco schools, the caregivers there have higher education levels as well as higher family income overall. Okay, so now we'll move right into, we're gonna do aim 2 first because this is just kind of how Sarah and I started with coding. So our aim 2 was to measure observed psychological safety in school teams. And so to do this, we're using O'Donovan and McAuliffe's 2020 psychological safety observation measure. And our main question guiding this work was, what are behavioral indicators of psychological safety in diverse school mental health teams? And we started with coding 3 families. So I'll review the code book first, and then I'll go over some of our preliminary findings. And so this is the code book that was put together by O'Donovan and McAuliffe. And we have, just to orient you to this graphic, they highlight several categories and then several behaviors that correspond to those categories. And as you're watching video or as you're coding, we're looking for these behaviors in the caregiver, the teacher, and the school mental health provider. And So some examples here, as you can see, for voice, in the category of voice, some behaviors that we would be looking for would be any of the team members asking open-ended questions, correcting others, communicating opinions, even if they disagree. For defensive voice, we see things like showing aggression, raising voice or large gestures. In the silence category, we see closed body language, no eye contact. In the supportive category, we see things like active listening, giving attention to the speaker, sharing future plans. And so we kind of go through all of these. And the way that we coded was we coded behaviors per talk turn. So whenever, one speaker ended and another started to speak. And we also worked, as we were coding, on clarifying coding rules based on, the different categories. For example, with asking open-ended questions, if a person was just reframing their question for clarity, we would only count that as one instance of asking an open-ended question. But for example, for acknowledging achievements or congratulating or expressing appreciation, we would count every instance of somebody saying something positive. And so that's just kind of to give you an example of how we were coding. If you could go to the next slide, Sarah. So this is a continuation of the categories. So here we have some additional ones. In the unsupportive category, we have interrupting. And we also, as we were coding, we noted some additional behaviors that we felt were worth coding. And so these are some suggested codes that we added. Which include not directly answering a question or a prompt, or including ignoring a question. We also have this additional directive or firm tone. And then also behavior management that seemed unnecessary in that moment, or that distracts team members. So it's verbal or nonverbal management of student behaviors. And so as we continue to code, we'll see if this is something that we end up including. And then we have learning or improvement, which includes things like asking for help, asking for feedback. And then the last one is familiarity. So really, when we see people talking about personal non-work matters or laughing amongst each other when jokes are made. So once we code everything, and we're summing up these counts, and so there's the total observed behaviors. So you'll get a sum for everything up top, and then we also split the categories, and we sum the categories that indicate high psychological safety within the team. So those include the voice, supportive learning or improvement, and familiarity behaviors. And then we also have a sum for the categories indicating low psych safety. And finally, at the end of, once we're done coding a video, there is this additional team level score that we go through, where it's on a scale from 1, strongly disagree, to 5, strongly agree. And we're really looking at just overall in the team, were there enough opportunities for participants to ask for help? Were certain team members dominating the discussion? Were decisions made together? Did people seem genuine, or did it seem like people were holding back? And so we assign this a code from 1 to 5 to capture the team level score. And so now I'm going to present just some initial findings and themes from the first 3 videos that we coded. So for the first team, just to give a little bit of context, sorry, is there a question? Okay. So for the first team consisted of a caregiver who was a Black mother in the San Francisco school district. The second team was a caregiver that was a Latina mother, and then the third team was a caregiver that was an Asian mother from the San Francisco site. And so first I'm gonna just kind of to orient you to this graphic now. These are not, this isn't the whole code book, but what we did was we pulled out sort of the top occurring behaviors from each of the, and we sort of grouped them. So these are all behaviors that were most common that indicated high psychological safety. And so some, just to kind of go through the green is the first team, the red is the second, and the purple is the third team. And I'm gonna just highlight some of the themes that, so what we saw with the school mental health providers was that most often a behavior that they showed consistently was asking open-ended questions and sharing procedures, knowledge, and experience, which makes a lot of sense because in the context of the meeting that we recorded, this was the initial meeting, sort of orienting everybody to the intervention and everybody's role. So we did see a lot of that. For the parents, the most frequent behaviors that we noticed across videos included providing information and giving verbal or nonverbal attention to the group, which again makes a lot of sense in the context, right? They're learning about what this information or this intervention entails, and then they're providing a lot of information that's helpful to the team about their child or about, you know, information that could be helpful to the team. And then finally, we see that teachers similarly tended to share procedures and knowledge and give a lot of attention to the speaker, but also seem to have more variability in their behaviors. So for example, if we look at the teacher in team one, the green column, we see that there was a lot of acknowledgement of achievements and congratulating and expressing appreciation there with the number 8. There was a higher sort of laughing about jokes. For team 2, we see that the teacher did a lot of active listening, verifying or paraphrasing information for the group. And then for the third team, we see that the teacher additionally communicated opinions often, even if they disagreed with a group. So we do see some variability by teachers. And then finally here we see that there were some shared and unique team strengths. So we see that overall the teams, the teachers and leaders across the board shared a lot of procedures, knowledge, and experience. And we also see that there was a lot of attention given, but we also see that between the different teams, for example, again, in team 1, there was a lot more acknowledgement of achievements and expressing appreciation. There was a lot more use of inclusive language, especially from the school mental health provider. And then in team 2, a unique piece is there was a lot of active listening from the parent and the teacher. And then in team 3, we see that there was lots more of asking open-ended questions across the board, and also lots of agreement and responding positively or enthusiastically to input. Oh, and one thing I didn't highlight in the team 1, there was a lot more laughter from the parent and just across the board when, you know, making jokes and things like that. And so now onto the categories where we see low psychologically safe behaviors. So for the first team, we didn't observe any negative or low psychologically safe behavioral indicators, which is great. For the second team, we see that there was some more closed body language from the parent. Yes, so C is for caregiver, T is for teacher, and then S is for school mental health provider. Thank you for that question again. And so yes, we see that the teacher, for example, did a lot more interrupting here. There were some more directive, firm tones used from both parent and teacher, and just overall, some more of the behavioral indicators of low psychological safety. And then in team three, we just see a couple of no eye contact and some not directly answering questions. And we just wanted to highlight a couple of sample quotes of and behaviors. So some of the examples of supportive quotes that we saw were a teacher saying to a student, "I think that you are so nice and kind and helpful, and you work so hard in our classroom all the time." Another teacher to student comment was, "It's our job to kind of figure out how to help you. We're going to work together to make it the best we can." And then some examples of unsupportive category behaviors were a teacher to a student saying, "We're going to make changes, right? We're going to make bad habits go away, a better attitude." And then a parent was observed non-verbally prompting a student to put down a piece of paper that the student was holding, despite the paper not being a distraction from the speaker or the task. The child was just simply holding it. So these are just sort of some examples. And then finally here, this is the group score. So as you can see, the collective team score sort of highlights what we've seen in the previous slides, right? We see that the first team had an overall higher score, indicating higher observed psychologically safe indicators. Team two with the lowest score. So we see that there wasn't as much opportunity for participants to speak up in that group. Decisions didn't seem to be made together by the entire team. The atmosphere was less constructive, and people seemed to hold back a lot more in that team. And then we see a similar score for team three.
All right, Nicole's question, who is rating here? So it was me and Yesenia. We spent a long time really developing and redeveloping and iterating the code book, adding to it, but I think we are ready to train coders.
Yes.
All right, so for A1, again, we're trying to assess psychological safety in school teams. Of course, novelly with the parent or caregiver as a team member, which does not occur very often. And so we're curious to see to what extent did school teams with Asian, Latina, white caregiving team members experience psychological safety. And so to give a quick snapshot of the numbers, these are just the team. So it's again, team level psychological safety. And the ends are a little lower than the total because these were paired scores. And these were the teams that had at least 2 reporters out of the 3 complete the rating at baseline and at post. And so for teams with Asian caregivers, there are 9. For Latina caregivers, there's 24. White caregivers, there's 15. And at baseline, we saw that teams with Latina caregivers scored lower than those with white caregivers. And then by post, we saw teams with Asian caregivers scored higher than those with Latina caregivers. So we're not necessarily drawing any conclusions, but we do find it interesting that some teams really enhance their psychological safety, especially in the Asian and Latina among the teams with Asian and Latina caregivers. Some dropped. And essentially this effect at baseline may have been the very high ceiling effect with the teams with the white caregivers. And so perhaps at post, their scores dipped but thinking about regression to the mean sort of effect. All right, so then beyond these 7 items, this very well-validated 7-item scale that Edmondson had developed, we're curious to assess the cultural relevance. So among the behaviors that we're trying to observe that Yesenia just covered, which were the easiest for caregivers when they felt safe in a team? So they were prompted with this question, and the original proposed method that we had proposed in our aims was just not feasible given the R01 constraints. And so we were going on a school schedule. It was really hard to recruit caregivers after the program was done to do interviews. And so instead, our workaround was developing 3 question sets that perhaps hopefully overlap. So they can endorse when they felt safe in a team, their perception of some of these exemplar behaviors from the observational scale, and they rated themselves, their perception, on a scale of very hard to very easy. It's -3 to 3. They were also asked to endorse the top 3 things they're most likely to do in a team setting when they have an opinion someone else might disagree with. So in other words, when they had a spicy opinion. And then they were asked to endorse the top 3 things that will help them feel more comfortable. So thinking about some facilitators here with sharing their spicy opinion in a team setting. All right, so when you felt comfortable working in a team, how easy was it to? And so these were the behaviors that were assessed. And again, they should look familiar and overlap with a lot of the behaviors that we saw on the observational measure. These represent the means within each team group. So teams with white caregivers, teams with Latina caregivers, teams with Asian caregivers. Notably, on a scale of very hard to very easy, none of the group means fell below neutral. And so no one endorsed, at least the means did not fall below neutral to somewhat hard, very hard. And so just neutral to very easy is displayed here. The darker the color of the rainbow, the higher the mean, meaning the easier the behavior is for them. All right, so let's review each step by step and go through some of the highlights. And so we were curious to see what behaviors were endorsed as easy or very easy. And so that means anything that fell at 2 or above. And we see that sharing information to help a team member was one of the easiest behaviors for all the parents. And we also see that having fun, sharing jokes, and laughing had the highest mean for Latina caregivers and was also endorsed as an easy behavior for white caregivers. And for the Asian caregivers, they endorse showing support when a team member achieved a goal, like saying congratulations, as the easiest behavior. That was also endorsed as one of the top behaviors by the other caregivers. And asking questions about their work that they're unsure about was in the easy range for white caregivers and white caregivers only. And so then on the flip side, what was hardest to do, even when they felt safe? And so it's a quote unquote hard because nothing fell in the hard range. So just like less easy, perhaps neutral, it doesn't come as naturally to them. All right, so we wanted to look at the 3 behaviors with the lowest mean ratings for each group of caregivers. And notably, there are 4 here for the Asian parents, which all fell under the somewhat easy range, in between neutral to somewhat easy. And there are 4 because 2 of them tied. One of these behaviors among the Latina caregivers fell below the somewhat easy range, and none of them fell below that range for the white caregivers. And sharing a spicy opinion was the hardest. for the Asian caregivers, and that was followed by talking about personal things. Talking to a team member about a mistake they made was the hardest for white and Latina caregivers. And then there are unique ones to each group. So for white caregivers, another somewhat more difficult one was telling someone on my team about a mistake that I made. For Asian caregivers, asking a team member for help with their work. And giving team members feedback was endorsed on average less easy by the Latina caregivers. So our next question was, what are these caregivers most comfortable doing when they do have a spicy opinion, right? Because in line with the definition of psychological safety, feeling safe enough to take interpersonal risks and put themselves out there. And so when we look at, we ask them to endorse the top 3 items, and they're represented. So this visual represents just Latina caregivers. And to orient you to this, bigger bubbles means more frequent endorsement, and the lines between the bubbles mean that these behaviors were correlated. The thicker the line, the stronger correlation. So I'll present this piecemealed to everyone just to break it down. And so these 3 items are not comprehensive. And so when they have a spicy opinion, Latina caregivers reported they were most likely over 70% to bring it up during a team meeting, when someone else communicates that opinion, and when they're asked. And there are positive correlations among all 3 items. And so it starts to paint this context, right? Perhaps during a team meeting and they hear another person's opinion and then is offered a chance to speak up, perhaps then they feel comfortable sharing that. Oh, Nicole, you said, can we share an example of a spicy opinion? Certainly. So in the context of our program, it might be the teacher has a goal in mind to work with their student, and a parent isn't comfortable with that goal, feels like, they don't see that behavior at home or anywhere else, and perhaps the teacher is exaggerating. And so their opinion would be potentially like, no, let's work on something else. Or perhaps saying like, well, we can work on that, but does my child really need, X reminders or X number of rewards? All right, great question. I'm going to hold off on answering that one. Great one. All right, so for the white caregivers, they also appear most likely to communicate their spicy opinions in the context of a team meeting, and to a lesser extent, 44%, compared to the 60 when asked. And having someone else communicate a similar opinion seemed less important to white caregivers. And noticeably, there were correlations, but not all around. And so someone bringing it up, a similar opinion doesn't necessarily mean that it's in a team meeting. And then among white caregivers, one-on-one meetings appear to be a less popular context than a team meeting, but there were parents who seemed comfortable with either situation. The positive correlation. And then a smaller portion, about 17% of the Latina caregivers were likely to bring it up in a one-on-one. And then 10% endorsed they would keep their opinion to themselves and just not share it at all. But in contrast, no white caregivers reported they would keep their opinion to themselves. And so that's not represented as a bubble here. And a couple of them said that they would share it casually over a break or lunch. Writing an email was also not as popular, but about 20% there. And similarly, sharing an opinion casually over email were the least popular among Latina caregivers. These correlations would not run with a much smaller sample of Asian caregivers, but just to show you a quick snapshot of what they're endorsing, their highest endorsement were very similar to the Latina caregivers, although as a group, they just had lower endorsement for most behaviors overall, and they seem to have differing opinions. And like white caregivers, no Asian caregivers endorse keeping their opinions to themselves. All right. And then the top 3 things that would help them feel more comfortable sharing a spicy opinion. Their items have some overlap on purpose. And there are, again, group by groups, and I'm just going to highlight some similarities and differences. And so all 3 caregivers said when a teammate brings up the topic or asks for their opinion, that helps them feel most comfortable. That was one of the highest endorsed for all 3 groups. And after teammates respond positively to other people's feedback, was also highly endorsed among the white caregivers and Latina caregivers. And after all teammates have shared their opinions, was uniquely helpful for Latina caregivers, while after they've gotten feedback outside of their team that their opinion would be helpful to share, was endorsed by white caregivers. Also noticeably, white caregivers were like to a large extent endorse that they usually feel comfortable sharing their opinions, even if a teammate might disagree, which was certainly not the case for the Asian caregivers. And among the Asian caregivers, having fun and personal relationships really appeared to be important for them sharing their spicy opinions, but it was rated as one of the less comfortable things for them to do, which was interesting. All right, and the next steps. Senia, you want to chat about that?
Sure. So for our next steps, we're really excited to really dive into the complete data set when we have that, because we're already just really excited about some of these, preliminary and exploratory themes that are coming up. And so our next step in terms of the observational data is to train coders and continue with the behavioral coding, and continue refining the code book as we go. Once we have the complete data sets, we're also really excited to examine correlations between the team level psychological safety data that we have and the caregiver reported implementation outcomes. And then lastly, dive into our third aim, where it's really examining the convergence between, if there is any convergence between the quantitative and qualitative data that we have. And I think now we have some time for questions.
And to answer the first question in the chat, who would be responsible, considered mainly responsible for fostering psychological safety? And that's a great question. The context of these teams, the school mental health provider is considered as the leader. And so they're the ones delivering the program. They lead the discussion of each of the 3 components. They implement the weekly parent and student groups. And so they're the person who liaises with all the team members on the most regular basis. So we would consider that it's really the leader, the school mental health provider, who's bringing forth the information, the ideas, to be the one to help foster. Although, of course, everyone, as we observe in these meetings, have also a lot to do with the overall psychological safety and like verbal and nonverbals that they're presenting.
We'd love to hear any questions or any feedback, or suggestions, even if you have any, as we continue coding and diving into the data.
Yeah, another question from Louisa, why there isn't data for Black caregivers. Or our proposal wasn't focused on Black caregivers, but also if we did have enough of a sample, we totally would incorporate those analyses as well. And we're just not recruiting. We're also under recruiting for Asian caregivers too, hence not being able to run some of the analyses we'd like to see. And then are we looking at demographic breakdown results for teachers and mental health providers? So one thing that we would love to get consultation about is how to look at the racial differences among team members. And so with more racially, ethnically homogenous groups compared to heterogeneous groups, whether or not that conveys differences in psychological safety. And then the student point of view, we have not, but they are a participant in the study. We didn't include them because their role is also very limited in that meeting as the person who has the least ability to share their opinions and thoughts too. Just the constraints of a school meeting fitting within the timing of a teacher's and school mental health provider's day.
So I do think it would be really interesting to do that maybe in the future, especially if with older kids that are participating, because we also definitely see differences in how the students are responding to the team around them and their involvement in setting the goals and, you know, kind of taking ownership of the tasks that they're being delegated. So definitely something that would be interesting to incorporate in the future.
I had questions about the coding itself. It sounds super detailed, and I was really excited about it until I realized you need video for it. But I'm curious about how the ratings that you're making at the end are comparing to more like the behavioral counts, and if you think those like kind of Likert scale items might be a little bit more, like might be reliable enough to be able to use like if you're observing a meeting live or something like that.
Yeah, I mean, I think so far with our very limited data, we do see that there's some overlap and that it aligns well with you know, the overall sort of um, team level psychological safety. So I would say that it likely could be, but um, yeah, it's something that we'll hopefully have a better answer for once we were able to go through and code all of the rest of the videos.
Yeah, I had the same thought when we were coding that final like 7-item scale. And how great would it be if that was reliable enough to just capture it, right? You're watching the meeting at the very end, you fill out that 7 items. So TBD, we'll let you know.
Yeah, I think any sort of measure that could be kind of done in real time would be a huge contribution because I definitely sit in a lot of team meetings that I will probably never get permission to record. But it would be really nice to have another way to kind of capture some data other than just like qualitative notes.
Exactly. Questions in the chat. Have we looked at race, ethnicity of the other team members, whether that's associated with their PS behaviors? Not yet. Yeah. On the docket. And then do the slides include references for the measures? Always helpful to see measures. They don't, but we're happy to include them and then send out a copy of the slides. Well,
Sarah and Yesenia, this is so wonderful. It's great to hear about just all of the um, you know, rich work that you've done so far. I'm just curious if during this process, if it's sort of raised your thinking about other kind of important team constructs, especially within these meetings. For example, shared mental models, especially when you're talking about that lovely construct, the spicy opinions. And how do we get people all thinking about sort of the same conceptualization of a behavior? So just curious if it has sparked, you wanting to pursue looking at other team constructs.
Yeah, definitely. I think, well, one that's very closely tied is the trust, right? And we initially had thought about maybe including something similar to that. But I think we also noticed with as we were coding that team members, there's definitely space to continue. So far, for the observational measure, we're noticing that there's a lot of behaviors that are kind of more relevant than others, and so we're really excited to continue looking into those.
Yeah, and as I'm learning this set of research exactly, like the difference between trust and psychological safety, and when we're looking at behaviors, how can we really kind of isolate these as psychological safe behaviors when there's so much communication involved? That's a different construct. Cohesiveness, that's a different construct. And so in terms of, trying to figure out the behavioral indicators, where does one end and another begin? And the dynamic of it too, right? And so is there something more so about the responding to the team member that is on the psychological safety side versus like direct, like verbal communication, the content of the communication? And so that's something I feel like we're constantly discussing while we're trying to figure out the codes and figuring out, as Yesenia said, exactly the ones that are most important to this construct in particular.
And just to add with the shared mental model, that's actually something we were thinking about in terms of when we were looking at why maybe um, some of the psychological safety scores dropped from the first to the from pre to post, right? And we were wondering if maybe that's sort of like an effect of that, where maybe some parents came into it thinking that it was something, and then sort of the we see the scores drop because then they realize that it was something else. And so I think that's a really good point as well in terms of exploring other factors or other mediators for why we see the differences in or changes in psychological safety across the intervention.
Well, I see that we're just at the top of the hour. Sarah and Yesenia, thank you so much for sharing your really, really impressive work. We will send the recording and slides out to everyone in the next week or so. So appreciate you all being here and join us next month, October 16th. Take care, everyone. Bye.
Bye.
Thank you, everyone. Bye.